fellows competition. We get fellows to submit multiple cases and we choose the top 3. So this is in the realm of the bizarre, rare, and spectacular. So we're going to start with their third winner, which is Dr. Cong. She has a very interesting presentation of a case of inflamed arteries.
Hi, my name is Huong. I'm a PhD in cardiology at the University of Montreal. So I'm going to present a case of inflamed artery vessel disease. So let's start with the case. So this is a woman of 26 years old. She's actually a nurse. She's known actually for diagnostic of Takayasu for 2 years ago, so since 2015. She is following up by rheumatology, so she's on methotrexate, an anti-IL-6, and prednisone. No family history of coronary artery disease. She's a non-smoker. So a little bit a year and a half ago, she started to have atypical chest pain. Her physician ordered a stress test, which was positive, and then she was sent for a cath lab. So the cardiologist did an angiogram, and we saw a left main with a 65% stenosis. He did angioplasty with a drug-eluting stent at that time, 3.5 for 8 millimeters, with a kissing in LAD and circumflex. And she would put on dual antiplatelets. Now, this is actually the angiogram that was done a year and a half ago. So let's see. So we can appreciate on the left view, we can see a stenosis of the left main. And when we see on the right side, a spider view, we can reappreciate the left main, quite a significant stenosis. So and now this is the angiogram after actually the angioplastic. So we can see actually with the stent deployment, it was a really good result. Now what is interesting is a year later, she came back actually with the same type of atypical chest pain that's going on for several months. But while she was having steroid tapering, so instead of having like more than 10 milligrams per day, they lowered her dose to 5. And her physician ordered a stress echo, which shows this normal EF, no wall motion abnormalities, but clinically and electrically positive. At that time, since the symptom was atypical going for several months, her physician did order, first of all, like a cardiac angio scan. So what we can see actually, oh, I'm sorry. Just sorry. So what we can see actually from the left scan view is we can see the stent and we can see intra-stent stenosis, and we can even see the stenosis that extend beyond actually the stent. So it extends into the LAD. Now on the right side, we can see actually that the stenosis extend into the circumflex. So we have a significant intra-stent stenosis. Now at that time, now what would you do actually? So we can ask the audience, so you can raise your hand. So who will order like an angiogram and percutaneous revasc? Okay, so there's no one. Who will actually ask for surgical consultation and surgical revasc? Okay, so and who will do further imaging for disease activities? Okay, minority, but it would be the 100%. So what we did actually is we ordered a TAP scan initially, and you can see the arrow actually is there's a FDG retention in the ascending aorta and some capitation of the left main. So which is suggestive of active disease or active inflammation in her case. So the two previous imaging did suggest the diagnosis. Now we actually did ask for a coronary angiogram just to confirm to see. So we can see on the left side, we can appreciate the stenosis and actually intrastent stenosis, and it is extended to the circumflex as well as the LAD. So another view, we can really appreciate that's real imaging, the intrastent stenosis. So at that point, what we decide to do is we decide to just try to come out of the cath lab. Then we discuss as a heart team, including her treating physician, cardiologist, and cardiac surgery and her rheumatology to see what are we going to do with her situations. So actually, this is a review article, a Chinese review, retrospective review, that they look at patient with Takayasu arteritis and who has coronary artery involvement. And among those patients, around 10% of those patients has coronary involvement, which is a good percentage number. And 50% of those patients has left main involvement. So it's not uncommon. And the majority of the symptoms actually is angina. We can appreciate and we can learn that when the disease is really active, it's really bad prognostic. So this is a review from a French group from Salpêtrière. And actually what they look at is they look at patient who has Takayasu and who underwent endovascular intervention, and they look for complication after that. And what they can see is you can appreciate that they have more complication after the procedure if they were really inflamed. So you can see with the biological marker with the sedimentation rate and the CRP that when they have increase of those markers, which mean active disease, they have more complications. Now, how do we treat those disease? So initially, if the disease is pretty in the cold status, then the patient only needs steroids. But as the disease progresses, so if it becomes really active or in refractory cases, we not only need conventional immunosuppression, but also like biologic agents like such as anti-TNF, alpha, rituximab, and anti-IL-6, which she actually got. This year, a Chinese group published like a review of patient who has Takayasu and coronary artery disease, PCI versus CABG. Although the number is pretty low, but what we can appreciate is the group that had PCI has much higher incidence of restenosis. So let's return to our case. So we came out of the cath lab, then we decided that we try to cool down the disease. So what we gave the patient is we give steroid pause for 3 days, and then we add sirolimus to her medical regimen. Then she was following up in the CCU. We did repeat a PET scan 10 days later, and there is resolution of the inflammation. So there's no more captations of the left main on the PET scan. And at that time, we say that the disease has been cooling down. So we decided at that time that she is ready to go to the cath lab and has a PCI of her left main to the LAD and circ. So when she came back actually to the cath lab, we first did the OCT of the pre-dilatation. Is there? So okay, we're just going to play the. Sorry, I'm sorry. Okay. So this is actually a pullback technique that actually we are in the LID. So we're coming back. And you can see well the lumen. Now you can see now there's narrowing of the lumen. Sorry. I'm just going to show it again. So there is actually a narrowing of the lumen now. So you can see that there's the yellow line outside is the previous stent, and you can see there's a thick layer, which is the intima proliferations, like fiber optic proliferation, that is consistent with the disease. That is in the left main, starting from the LLA to the left main. Now we're back to the catheter. So what we decide to do is, this is a technique that has not been described evidence-based, but we discussed and it seemed rational to do in the patient. So first we did balloon angioplasty with medication. So we did with paclitaxel, which we choose a different one from the one she got a year ago from her stent. Then after that, we insert stent in a mini crush techniques. And we use another one. So we use Resolute, which is zotarolemus, so which is a different one. The one she got in 2016 was Zion. So we tried to use two different medication to actually inhibit better the fibrotic proliferations. It seemed rational, but there's nothing really described. Then we just deployed the circumflex first, and the left main and LAD after, and then we post dilate. So this is the result. So it's a pretty good angiographic result. So this actually is the OCT post dilatation. So again, this is a pullback technique, so we are in LAD. Then you can see actually now the stent, that's the new stent. You can see it's well deployed. There's no actually dissection or thrombus, hematoma. There's no complications, no malpositions. And we are going back to the left main. And everything, this is the bifurcation. And you can appreciate also the both stents of the previous and the new one, and it looks good, as a good result. So actually, then she was discharged. And actually, what is interesting is just 2 days ago, she came back for a follow-up angiogram. So basically, her physician has saw her, and she has much less chest pain, but there is some residual. So that's why her physician did ask for an angiogram. And you can see, I appreciate that it's still good, adequate perfusion. There's no stent restenosis at all. And we also did an OCT following up. Again, we start at the same sequence. So we a pull-back technique, and here we are in the LAD. So we can see the lumen is still patent. We see there's no stenosis, no black in this lumen. And so now we can see the stent. So we are more in the proximal LAD. We see the stent, and we see there's no restenosis at all. It's well deployed. There's nothing at the edge, no dissection, nothing, no thrombus, no plaque. And then we are going back to the left main. And we see that this is the bifurcation of the circ, and then it's well, see that both stent, it's well deployed, and we can see actually even less inflammation of the thickening of the intima, because we did ask for, we did order a PET scan also, and there's no active inflammation, so you can see there's no more thickening that you saw on the previous OCT. So what's the take-home message? So actually, when patient has an active disease, active inflammations, at the time of any intervention, there is evidence that it will increase the risk of complications. So if the procedure is not urgent, it would be better to wait until the resolution of the inflammations. Of course, we have to consider that there is a considerable incidence of restenosis. And restenosis is much higher with percutaneous intervention than with surgical approach. Percutaneous intervention with a new generation of DES and good appropriate like dual antiplatelet treatment would be an adequate option. And also, if we are tapering steroid, it has to be judicious, not to reactivate the disease if we taper too quick. So thank you so much for being here.